All right, so welcome to the session on the Global Patients Congress of IAPO, covering the topic of health technology assessment, value-based healthcare, and HTX next generation. My name is Jan Geisler. I'm CEO of Padvocates. I've been a patient advocate for many years, and I'm very delighted to chair this session with a great panel of speakers. The whole topic of health technology assessment is extremely important because more and more countries are using HTA as a bridge between healthcare evidence and decision-making on reimbursement of medicines and access. And of course, the patient voice is extremely important because how can you take great decisions without involving patients in what really counts for patients? And that's why I have three great speakers with me. And as always, the time pressure and the challenge of a virtual Congress because the pandemic doesn't allow us to do it differently. So I'm speaking into this camera, and I'm welcoming you to this session to speak about this topic. So very delighted to have as first speaker David Granger from BioIntellect. He's head of global health outcomes and policy. He's going to introduce us into the topic with the first talk. Just as housekeeping, we're going to run through all three presentations of 10 minutes, one by one, but please don't stop having questions and posting them on the Q&A, which you can see on screen, I think. So we're going to watch the Q&A and we're going to go into your question if time allows, because very strict timekeeping on this Congress. To answer that, and the speakers will also watch that and post answers to the questions. So now, handing over without further ado to you, David, to speak about your perspective on value assessment in HTA, patient centricity, and decision making.
Thank you very much, Jan, and good evening, good afternoon. It's a great privilege and pleasure to be part of this panel session today. As Jan has mentioned, this is a fairly complex topic, HTA in itself, let alone how we achieve patient centricity in it. And we're going to try and do justice to this complexity in a very short space of time. So let me jump into it. What I want to do by way of sort of really providing some context to this discussion, and then the following two speakers I think will flesh it out more in terms of what's going on in more detail about patient engagement and participation and where that is going. So in order to give this context, I thought it would be useful to start with a very, very simple definition, which sort of really suits the purposes of trying to establish this context. So from the simplistic point of view, I'm viewing HTA as a process that compares the effects of a new health technology with an existing one, and with a focus of that comparison usually around trying to assess the value that that technology brings to patients. So that's a sort of a simple working definition for our purposes today. And I think Anne is going to expand on that with something more extensive and up to date. Secondly, I wanted to touch on why is this so important, this whole concept of involving patient centricity within HTA. Now, it's always difficult and sometimes fraught to make comparisons across countries with something as complex as this, but we do know that when you look around the world, the countries that are using HTA, there still are quite often significant time lags between a regulatory approval and reimbursed access for patients. That varies from country to country. We sometimes see differences in the specific decisions about technologies, or for example, the types of restrictions that might be placed on them. And then of course, the technologies themselves are evolving greatly with the science. And we also have new countries coming on stream, if you like, in terms of venturing into health technology assessment for the first time. So it becomes really important, I think, to be able to continue to evolve and become more capable and sophisticated about how the voice of patients and advocates is incorporated into HTA. So with those couple of opening comments, I want to then really cover over the next couple of slides three things. One is a little bit about trying to understand what it is that HTA agencies and payers want and look for in terms of assessing value. And at the same time, thinking a little bit also about the producers of those health technologies. What are they looking for and trying to do in terms of supporting the value of their technologies? And then moving from that, what do we understand about evidence that supports these value propositions, and in particular, where is it that patients and advocates can particularly strengthen and add to that evidence so that the process is done in a better way. And then finally, I want to finish up with some brief comments about if we're going to put that effort and investment into increasing the patient voice, if you like, in this whole process, we need to make absolutely sure that the decision-making process is able to integrate multiple inputs from multiple stakeholders in a way that produces appropriate sorts of decisions in a transparent and reproducible way. So that's what I'm going to try and cover in the brief time available. So let's talk a little bit about HTA and payer needs in this whole process. We'll talk about the diagram in a moment, but we know from work over about the last 10 years that the things that are really important to HTA agencies and payers in assessing new technologies are really fairly straightforward. They're around the added clinical benefit with consideration to the amount of unmet need that exists in the condition in question. But they might also be thinking about equity across the population that they're treating. They might be thinking about budget impact and about opportunity cost. And that opportunity cost piece is often covered in the approach to cost effectiveness and the application of cost effectiveness thresholds. So, you know, a fairly defined set of needs, if you like. And then in the last few years, particularly 2017, 2018, ISPOR, the International Society for Pharmacoeconomics and Outcomes Research, conducted a task force to look at this question about value as well. And you see the diagram on the right, which has become known as the ISPOR value flower. Some people call it a value wheel, and it has a range of value dimensions or elements around the outside. So up in the green on the upper right, you see these areas of qualities gained and net costs. And those are really the ways in which most agencies really conduct their value assessment at the moment, the qualities piece incorporating the added clinical benefit and quality of life. And then around the rest of the wheel, you see some other things in different colors. And these are some things which are often important to other stakeholders, often more difficult to evidence and to demonstrate in a robust way. And so therefore they're not always treated the same way in an HTA process. And some of them are frankly often very uncertain, and so that needs to be taken into consideration as well. But it starts to give you a little bit of a sense about, you know, if some of those things around the wheel there are important to patients and carers, then you need to be thinking about how you might support that in an HTA process if you're able to participate. And then moving down to the lower bullet points, you know, in terms of evidence of value, the added clinical benefit, the resources that are used, to some extent the quality of life impacts, those things can be evidenced through clinical trials. And that's what agencies rely on most strongly, is the evidence that comes from clinical trials of the new technology. However, if we're wanting to have a discussion about broader aspects of value, then it becomes really important that patients and patient advocates are able to have a voice to be able to add to that clinical trial evidence. And then even within that clinical trial evidence, it is also important that those voices are heard. For example, if the added clinical benefit is being measured in trials through a rating scale system, for example, it might be really important to be able to help an agency interpret that and understand, you know, what does a 3-point improvement mean on a 10-point scale? How does that really translate in terms of patient relevant outcomes, as we say? So the patient perspective can become very important there. Likewise, if we're talking about preferences, and this might be preferences for particular side effect profiles, for benefit risk balances, or for administration differences, and those things clearly would require patient and carer input as well. So in the time that I've got left, just to comment quickly about how you can pull all of this together. As I said, it's absolutely critical that if you're going to the effort to bring these diverse stakeholder perspectives into play, you need to have a way of making sense of that when you make decisions. At the moment, and it's critical therefore that those committees have skills in combining a range of diverse evidence from a range of stakeholders. And at the moment, the effort to sort of explore this and improve it is really focusing on a couple of different areas. One is around this concept of multi-criteria decision analysis or decision making. And that's a scenario where you sort of give weights and priorities to a set of those value dimensions that I mentioned. You score the technology against those different elements. You might multiply the scores by the weights, and you add all those up, and it gives you a quantitative expression of that. But it gives you the sense just by describing it. This could be quite difficult to do, quite difficult to get agreement and alignment on those weights and scores. And also for committee chairs, they tell me that it also runs the risk of taking away some of the flexibility that they actually value in this decision-making process. So that leads us to the second area that's being explored a lot at the moment, and that is what's called deliberative processes or deliberative decision-making. And I like this diagram down the bottom there, which comes from a couple of industry colleagues a number of years ago, where they divide the HTA process into these two things. On the left-hand side, the sort of more technical evaluation or assessment process, and on the right-hand side, the more appraisal and decision-making process. And you see around the right-hand side, around that right-hand side circle, a number of things like equity, precedent, acceptability, values, and preferences. And they're making the point that those things need to be pulled together into that appraisal. So this process of deliberative decision-making is really talking about how does a committee consider all these different inputs, different elements, and pulls that together into a decision. In recognition of how important this is, ISPOR that I mentioned previously, and HTA, Health Technology Assessment International, the two big professional societies in this space, they've recently established a joint task force to focus on these deliberative processes. And I had the pleasure of being part of that task force. And what we're trying to do there is really sort of describe and report on some best practice for this that might help agencies do a better job of it. That'll report next year. So I encourage you to watch this space in terms of what we learn about good deliberative process, because I think that's going to be critical. As I said before, if we're all making this effort to improve patient voices in the process, we deserve good decision making that can make sense of those multiple inputs. From my point of view, if you're looking for more information on what I've talked about, I work in this consultancy, BioIntellect, based here in Sydney, Australia. We work across a very wide range of stakeholders on a diverse set of issues, and happy to have a conversation about any of that. And you can contact me at that email address. And so thank you for being able to share this small amount of time with you. And a couple of those key references that I've drawn on are on the slide there. Thank you, Jan.
Thank you so much, David, for sharing your insights and the different perspectives, and also the need to pull together all the different, let's say, perspectives from different stakeholders. And in your talk, you have also mentioned Health Technology Assessment International, and that actually leads me into the second presentation. And please, as I said, everyone who's listening in, keep your questions and put them into Q&A so we can respond to them at the very end. As the next speaker, I want to introduce Anne Single from Health Technology Assessment International. She's chair of the Patient and Citizen Involvement Interest Group and coordinator also of the Patient Voice Initiatives. And HTA has been, I would say, a thought leader and a driver of patient engagement in HTA for many years, driving the discussion on how can meaningful patient involvement and patient engagement really happen in HTA. So I'm really happy to have you with us, Anne. So floor is yours. What's your perspective?
Thank you, Jan, and good morning and good evening. And thank you, IAPO, for this wonderful Congress and the invitation to speak. Before I begin, I just would like to acknowledge the Yagara and the Turrbal, who are the traditional custodians of the land where I live and work, and pay my respects to their elders past, present, and emerging. So, we're just flicking again, great. So a lot of my thinking today, Jan, is coming from a paper that I contributed to in 2018, and the lead author was Dr. Karen Facey, who many of you will know, and we published it in The Patient. And we had been asked to write about patient centricity in HTA, and the first question that we thought about was, well, hang on, can HTA be patient-centric? Is it compatible with HTA? Because given HTA is about making decisions about allocating resources across a population rather than an individual's needs or circumstances, and given it's really interested in numbers or data from randomized controlled trials or economic models, and given that other stakeholders need really predictable processes, and given that when committees are determining value, they've not just got the patient group that's in the room in their minds, they're also thinking about the impact for other other patient groups, you know, opportunity costs, the idea that what's being spent in one area isn't available to be spent in another. So given all those considerations, perhaps you'll be surprised to find that actually we thought HTA could be patient-centric. And we found that the goals of patient-centeredness, such as providing more appropriate care, improving safety, reducing error, meeting patients' expectations, and improving the public accountability of healthcare, are really very compatible with health technology assessment. But what we thought was that if health technology assessment is to be patient-centric, it must include robust research about patients' needs, preferences, and experiences. And it should support the participation of patients in its processes. So we said that the unique experiential knowledge of patients complements clinical research and helps us overcome some of the uncertainties in the clinical evidence, and it can inform that determination of value throughout the process. And we said that with effective patient involvement, health technology assessment can inform patient-centered healthcare policy. So I would suggest that if HTA is to be patient-centric and make a meaningful difference in patients' lives, it must have ways of knowing about those lives, either through research or dialogue for shared learning. So a couple of examples. In Scotland, where the Scottish Health Technology Group wanted to assess antimicrobial wound dressings, there was a real lack of evidence. And Dr. Naomi Ferns led some primary research with local patients, and she also did a qualitative evidence synthesis of a lot of published literature about patients' needs and preferences. And as a result, they were able to identify patient-important outcomes, which enabled consensus guidelines to be formed and recommendations made. In Canada, qualitative evidence synthesis was also essential when CADITH looked at CPAP machines for people with obstructive sleep apnea. They gained a picture of the real challenges in people's lives in terms of getting a diagnosis and their impact on daily or nightly life. So if achieving a health outcome relies on how a device is used, you have to talk to patients. In Australia, Chris Walker and the team at the Parenteral Nutrition Down Under did their own research to highlight the needs to provide essential retraining for HPN management, and they published that work themselves. In Brazil, patients put submissions into Conitec to raise that there was a vital education gap in the use of asthma inhalers and informed, again, patient-centric policy. Other times, patient groups provide important information about their populations, including the size, or in the case of NAS, they were able to provide information about the value of non-self-administered treatment for some of their members whose needs were being overlooked. And so HTA is finding ways to see the patients, but real limitations remain. Much of HTA is still done without patient involvement or with minimal patient involvement. Patient knowledge has to find a space within these institutions and structures that were really made for scientists and policymakers and manufacturers and regulators and healthcare providers who see all of these activities within different boxes. So you have research and development, followed by regulation, followed by HTA, followed by implementation. But for many patients, all those different boxes are really just a continuum associated with different criteria for accessing treatments, different risks. And patient knowledge struggles to find that space, in part because it is still disputed. It is caught in this knowledge war that's playing out in all areas of our society about what constitutes evidence and expertise. And in health technology assessment bodies, we tend to find this an awkward conversation because views are strong and varied. But what constitutes knowledge and evidence is very important conversation for patient centricity. And we need to find these safe spaces to have this conversation. Timing. If patients have not been engaged in the research and development of a medicine or treatment, how do we know that it delivers what matters to patients and their loved ones? Involvement during health technology assessment may just be too little too late. And of course, burden, time, resources, physical and emotional stress of involvement. And we need to do more to reduce this burden. We've talked about it for a long time, and we need to develop the mutually satisfying relationships and ways of working. So, despite all that, I have hope. And one of the hopes I have comes in the form of the new international definition of health technology assessment, perhaps surprisingly. But firstly, that new international definition acknowledges that when determining the value of a treatment, value depends on the perspective. In other words, the questions you ask influence the evidence you consider and the values you see. And it also recognises that assessment should happen across a life cycle of a treatment, which better reflects patients' continuums and may enable us to achieve outcomes that are difficult when HTA is seen as this singular point in time. I'm also encouraged when I hear HTA bodies exploring ways of better understanding the patient perspective. For example, CADITH has introduced a patient and community advisory group who's really there to look at CADITH from the perspective of the people who use health services in Canada. And the large European initiative Paradigm has brought together a wide range of stakeholders to drive forward patient engagement in research and development. And PCIG's Neil Bertelsen has led the creation of a toolkit to help health technology assessment bodies involve patients in early dialogue meetings with medicines development before phase 3 trials. If you're not familiar with KCE's work, Google this document because the Belgium HTA body undertook a large research project to answer the question, how can we improve the quality of our research on patient-related issues? And importantly, they did not shy away from the difficult discussions and took account of KCE culture. That is, they talked to their staff and learnt about their perspectives to determine the organisational readiness and form consensus statements about patient engagement. And finally, of course, it's always the patients and the patient groups who are really revolutionising healthcare. And just one example I wanted to give was Simone Layden's Neuroendocrine Cancer Australia and INCA's work, where they're applying the patient perspective to link up the system with patient-reported outcome measures work that collects data that may not only inform health technology assessment decisions and health policy, but also provides practical support for the patients in their discussions with their clinicians so they can talk about what's really going on in their lives rather than just answering clinicians' questions. So you can see there's contacts there. You can follow HTAI's Patient and Citizen Involvement Interest Group on LinkedIn. We have lots of resources on our website. Likewise, my organisation Australia Patient Voice Initiative has LinkedIn and Facebook. And if you'd like to learn more about that last project I mentioned by Simone Layden, we even have a segment on a webinar on our YouTube channel. Thank you very much.
Thank you so much, Anne, for all the insights and also for the resources that you have shared, because we know that we have very limited time in this session, but so much has been achieved by the three of you and the organizations you're involved in, that much has been done, much you can build on moving forward. And that's why, thank you for sharing this. And looking at what's coming next, I'd like to point to our third speaker, because I'm very happy to have Dalia Dawood from the National Institute for Health and Care Excellence, NICE, in the UK with us. I mean, NICE has been in the space of HTA for a very, very long time and has gone through a steep learning curve in terms of patient involvement, in terms of the challenges, in terms of evidence, in terms of getting the right patients involved and so on. And of course, NICE is in a good position to speak about, so what's next? How do we evolve? How do we move the needle? How do we do all what we've been asking for in terms of patient involvement? So Dalia is going to speak about next generation health technology assessment, or HTX, and thank you for joining us. So the floor is yours.
Thank you so much, Jan, and thanks for my co-speakers and for our attendees today. I'm really delighted to be joining you today to present on this topic, and actually it is really looking into the future of health technology assessment through our through our lenses and our research work that we will be discussing today. So HTX, or Next Generation Health Technology Assessment, is one of our projects that we are involved in. And in my presentation, I will be taking you through a bit of background about our research team within NICE and the work we are involved in, and about this future-looking project, HTX, its objectives, its vision, structure, and the work packages involved in HTX as a project, as well as patient involvement element of this project, and how we are focusing on bringing patient centricity into the realm of HTA from start to finish. So our team actually is a science policy and research team within NICE. It's a small team that works on a number of international projects. And we are partnering on several topics that looks at how to future-proof health technology assessment methods, and how to ensure that we are prepared for looking at the next innovation, and how we ensure that our methods are really up to speed and fit for purpose. One of the major projects that we are involved in is the subject of this presentation today, Next Generation Health Technology Assessment, or HTX. This is a Horizon 2020 funded project, and for those of you who don't know this stream of funding, it's a European Union fund, and the project runs for 5 years. It started in January 2019 and is planned to finish at the end of 2023. But as you know, with COVID and what's happening, things get a little bit delayed, but hopefully we'll be up to speed soon. Our consortium, our project consortium, consists of 15 partners. We are one of three health technology assessment organizations that are involved in this project. So we work with TLV from Sweden and then from the Netherlands. And the lead partner for the project is the University of Utrecht. And we also have patient advocacy group, the Euro RDIS, or the European Organization for Rare Diseases. And our project actually have specific objectives that are really future looking. It's about revolutionizing how HTA is conducted. So our aims, our objectives is to create a framework for the next generation health technology assessment, a framework that supports patient-centered, but also societally oriented real-time decision making. And the hope is this will be for integrated healthcare throughout Europe. And at the heart of it, we look at facilitating the development of methodologies that will facilitate and deliver more customized information on the effectiveness and cost effectiveness of complex and personalized treatments. So really focusing on the methods that address precision medicines and personalized medicine, how we can focus on the individual patient needs, with the ultimate aim really is for providing methods to support personalized treatment advice that is not only for health technology assessment organization, but information that could be actually used in the clinician patient, or in the clinician patient encounter, and direct the clinical decision making in a user-friendly way. So what we have as a vision really is, if you imagine that an individual presenting with a complaint to their doctor, who actually knows them, knows their clinical history, knows the use of the different health technologies, including the use of medical devices, e-health technologies, drugs. They know them, they know their preferences, their outcomes that they hope to achieve, what they value, and there is data to support the decision-making in this encounter that combines both RCT or randomized controlled trial data, as well as real-world data in a system or decision support system that actually facilitates this real-time decision-making within the patient-doctor encounter, and also allow them to make really informed decisions and person-centered decisions made using information that is available to them on risks, benefits, outcomes, and costs associated with a range of the possible strategies for their management. This will be a very much appreciated by both of the clinicians and the patients, but also this information is also made available to HTA organizations, whose decisions are actually informed by this information in terms of resource allocation. So they not only have the information based on the population level or even the subgroup level, but they also have at the individual level information. So this will benefit the payer's decision making. And this is actually what we envision as the vision for HTX, or next generation health technology assessment. And how we do that, it's actually the project is structured around work packages. So we have 6 work packages within the project. At the heart of it, there are 2 work packages that are methodological. So work package 2 looks at the use of real-world data and how to combine them with RCT data in evidence synthesis frameworks, and how to analyze them for risks, benefits, costs, and effectiveness in general. And also work package 3, which looks at using the newer methods of artificial intelligence actually to develop prediction models, to predict treatment effectiveness, to predict who's more subject to developing side effects from a particular procedure, for example. And these prediction models can then be used to inform the decision making. And these methodological developments are happening within case studies that form work package 1, that looks at specific range of diseases and treatment options. So we have 4 case studies that focus on myelodysplastic syndrome, which is a rare disease. We have one focused on diabetes, which is a very prevalent disease, and it looks at ranges and sequences of treatment as well as combinations of therapies. And we also have a case study looking at proton therapy, for example, for head and neck cancer patient, and another looking at multiple sclerosis and treatment sequences for multiple sclerosis. So applying these methods within these case studies will give us the way to see how they can work in practice actually. And then work package 4 looks at how to implement these methods, these innovative methods actually within systems and the processes of health technology assessment, but also bring in the discussion all relevant stakeholders. So we look at synergies between health technology assessment organizations and clinical guideline developers, as well as health technology assessment and regulators. And we try to, we're planning to have some form of live testing of how this could work in practice, how these interventions that are developed for these case studies could be appraised, for example, by health technology assessments through using new methods like policy sandboxes that health technology assessment agencies could use then as tools to try and test new methods before they are live or they are used for actual decision making. And at the heart of this work package 4 as well as work package 5, we have patients, and EuroRDIS is represented is the representative for the patient to ensure that they are involved in all the steps we are taking and in all our work and all the case studies, and have their input is actually from the start of the design of the project, as well as how to implement it within systems and processes, and to reflect patient centricity at the heart of the project. So for example, work package 4 for this project is actually looking, as I said, into implementation into systems and processes. And one of their major objectives is actually to increase patient centricity in decision making, to ensure that patient centricity is at the heart of the discussion between the regulators, the clinical guideline developers, and health technology assessment agencies, and at the heart of the payment models that we might need to develop for these new technologies and new methods of working for health technology assessment agencies. And work package 5, as I said, at the heart of it is our patient representative partners, and they are really making sure that we look at decisions, how they transfer between lower and middle income from high income countries where perhaps most of the highly developed patient involvement is happening, as to ensure that there is transferability for everything that we do into the LMIC settings as well, and the low and middle income countries perspective, and ensuring that we empower patients and engage them in the implementation of whatever outputs we get from our project. So really patients, as I said, and I say individual affected by a condition, should be at the heart of the health technology assessment processes, as we have seen from the first two presentations. But as I said, we are ensuring that they are represented also for even looking at the future and how to improve in health technology assessment. So our partners attend all the meetings for all the work packages. They are developing a toolbox to explain the different aspects of the research done and the new methods, using videos, written materials, webinars, presentations, face-to-face training sessions. So they had a summer school for patients as well. We also have stakeholders events that we are hoping that we will have some sort of fellowship program to allow patient advocates as well to join and attend our events. So to continue their involvement and ensure that their voices are heard when we develop the methods for the future. So really, in conclusion, I just wanted to say that we do believe that patient centricity is key to the future vision of health technology assessment, and the methodological developments are required so that involving patient centricity could be really supported by well-developed methods that facilitate patient-centered and societally oriented decision making. And this is happening. So really it's about also patient advocate groups to join in the journey. And we welcome everyone attending today to join our journey and to follow our progress. So we have a website, LinkedIn group, and we have a newsletter so you can sign up and know what is happening within the project. So thank you so much for listening, and I hope this would be a look into the future as well as reflection on the past for health technology assessment as well. Thank you.
Thank you so much, Dalia, for your insights and for sharing the plan of HTX and the future. I'd like to open the floor for questions now, and I've received a couple. Probably I'm going just with the first one. How can patient organizations be involved in HTX and follow the development? So that's a question that was probably going to you, Dalia.
So actually, there are, as I said, if you get to look at our website, there will be information specifically. There is a page for patients on how the project is involving patients and how patient organization could be involved as well. So this is the first step to be involved in that, and we also open for approaches about how to join in the journey, and specifically for patient organizations that are represented in the case studies, but also definitely open for others as well.
Thank you very much. Now, next question actually came from Ratna Devi, who's the board chair of IAPO and also based in India. The question is, how can patients and patient groups in low and middle income countries bring HTA in their countries where reimbursement mechanisms are very blurry? I don't know who wants to go first on that. David, Anne, Dalia. David?
I'm happy to start, Jan. It's a really good question, and I think there is so much to learn from other countries that are further down the track. I think one of the things that happens often when HTA is first raised as a potential policy and a process in a country's health system is that it often starts in academic and scientific circles, and the attention is mostly on the technical aspects. If you recall the diagram that I showed of the assessment process on one side and the appraisal and decision making on the other side. So the attention often starts with the more technical and scientific assessment part. And so I think one of the things that patients and advocates can do in countries like that is to try and draw attention early on in those discussions to the fact that this is a much broader process. And when you look at countries and systems like NICE, like Australia, Canada, there's been a very, very sustained effort over a long time to build these mechanisms and processes to bolt other things on to just that scientific and technical assessment. And so those are the countries that have made so much progress in this area of patient centricity. So I think it's trying to use the voice early on to make policymakers aware that it isn't simply about the science, and to then perhaps look to groups like ANS for some of the practical examples and tools and things that can contribute to that.
Thank you very much, David. And do you also want to comment on that? Because I know the patient and citizen involvement interest group is global, and you've looked at all the different countries from, let's say, those where HTA has been around for very long to those where it's developing. So what's your perspective? What have you done in that space?
I wish, Jan, we'd looked at all of the countries. But one project we are doing, Anki Holthoff and Yanni Muller, are leading a project for our interest group at the moment, which is looking at low and middle income countries. And it doesn't exactly answer Dr. Ratner's question, but one of the things we're doing in that project is just trying to get a sense of what the potential of HTA in those countries is and the potential for patient involvement. So we're assuming it may not look the same as it does for me sitting here in Australia. And so the first steps of that was a survey which surveyed Nigeria, South Africa, Brazil, and Indonesia. So, huge diversity amongst low and middle income countries, but just to get a feel for what sort of mechanisms there are there. And I would really support David's comments, because one of our thoughts around that project is, as we get to know those countries better, because as an interest group, we don't know them well enough, what sort of tools and resources can we help them with to support them on that journey of health technology assessment in their countries? And that's, we're very early stages with that. It's about a year in, and there's so much diversity and so much to discover. But actually, those are precisely the countries we'd like to be more useful to in the interest group.
Thank you very much. I don't know, Dalia, do you want to also comment on that, or shall we move to the next question?
Yeah, I definitely echo what David and Anne has said, and I think it's about starting small. It has to be steps first, but taking the first step is always the difficult one, and ensuring that there's a political will as well to engage patients in these discussions and ensure that their organizations are well informed about the processes, the methods, and how they can contribute. And if in countries where this is still in its start, then they can be looking at examples that are not necessarily the best advanced, but maybe starting with looking at examples from countries at a similar level of perhaps socioeconomic status or at the similar progress levels that can help them in implementing patient involvement.
Thank you very much. So next question that came in was about vaccination. So how do you think about HTA evaluation of vaccines against rare diseases such as meningitis? How should they be evaluated to qualify for reimbursement and answer needs of the public? So I guess that's maybe for you, David.
Thanks, Jan. Yeah, this is another very good question, and I wish we had more time available because it's a complicated topic. Vaccines bring a whole sort of additional dimension, I think, to the discussion because of the broader societal impacts that they have. And if you again go back to the slide graphic that I had of the value wheel or value flower, there are certainly dimensions that are somewhat unique to vaccines that need to be considered. What we see now in a number of countries is, as well as a sort of a primary HTA body, there may also be an expert vaccine advisory group, which will help by providing input on those additional sort of unique factors to vaccines. One of the things that concerns me sometimes about vaccines, I think, is that there is almost an underestimate of their value sometimes, because they continue to be at a superficial level, at least, one of the very, very cost-effective interventions that can be undertaken. But obviously, they do need to be subject to the right sort of technical evaluation as well.
Thank you so much, David. I see a lot of questions coming in, but unfortunately, my unfortunate task as moderator is actually to end the session, because we're at the end of time, and I know in 1 minute later, we're actually starting with the next session where I'm speaking. So I really need to rush off and need to take you to the next session. I want to thank you all, and especially my 3 speakers, for that very interesting session. I know that that short time doesn't do justice to such an important topic on patient centricity in HTA, but I hope with the resources that were presented, with the different activities in different countries, with different initiatives of the 3 organizations, and all the underlying consortia, you could get a glimpse on that, can Google more on the details. And because we've received a couple of questions about the slides, yes, they will be shared after the meeting, so you can go back, and even though the pace is always so quick on these things, we can't hold you behind the screen for 20 hours a day. That's why look them up there. I'm sure you can also contact the speakers. Thank you so much for listening in, and well, probably back to you, Kavaldeep, or am I just leaving?
Thank you very much. Thank you, Dalia. Thank you, Anne, and thank you, David. I think you've done us great proud for this. I hope patients really appreciate this session, and I think we'll continue our relationship in the future. Now, as for the audience, I think please leave this session, go back to the auditorium, and join Jan and me again in the patient looking at personalized healthcare, and there we will be discussing a lot more about how to know your patients well, and that's something that HTA could benefit from. Health systems have to look at the patients afresh and make sure they understand them very well enough, and personalized healthcare is very important. So thank you very much, and we'll see you across the time on the other side. Thank you. Go back to the auditorium and ring in. Thank you.
Thank you.
Thank you.
Thank you.